So thank you. Again, I'm Katie. I'm the interventional fellow here, and I get to have the privilege of learning from Dr. Sigaroa and the other interventional attendings that are here. So I've got a complex case of a patient that we did both rotational atherectomy and intravascular lithotripsy, as well as a bifurcation left main LAD PCI. So here's our case presentation. So this is an 85-year-old woman who has had a history of atrial fibrillation, chronic kidney disease with her creatinine around 1.5, type 2 diabetes. And she was initially evaluated in our valve clinic for aortic insufficiency and some moderate MR, but they were planning on intervening on the aortic valve. So she's referred from valve clinic as an outpatient to get a coronary angiogram as just part of her evaluation for aortic disease intervention. She had told all of them that she was not having any chest pain, maybe some mild shortness of breath. She's still able to walk around the home, I think using an assistive device like a cane, but is still very independent for an 85-year-old woman. Had denied any chest pain to them. When she comes into us, when we go and see her before we cath her, she is saying that she's getting some chest pain when she goes up the stairs, which is a new symptom that she hadn't revealed to us. Her EF is a little bit down at 45%, has severe AI, and her creatinine is kind of where it's always been. So I'll show you guys the angiogram picture. So first, we'll start with the right coronary. We used a JR4. The right coronary has some kind of diffuse stenosis, but the main thing that I wanted to show you all is that she's got some, we already can see that she's got some collaterals over to the left system. So we're suspicious that she has severe stenosis over there. And this is her coronary angiogram of the left system. So what we can see here is that she has severe distal left main stenosis. She has severe ostial left circumflex stenosis, which is kind of barely hanging on by a thread here. Proximal LAD stenosis, also severe and heavily calcified. You can see the outline of the calcium for the entire duration here. A couple of other views for everyone. So again, this shows on the left side here, we can see how severe that ostial circumflex is. And then on the right-hand side, again, the proximal LAD, there's also, it looks like it's not projecting quite as well as I was hopeful to, but there is a nodular calcification right around in this area that's that are seen on our actual on our screens here. But this stenosis is probably around the 80% range with the nodular calcium. So I'm just going to pause here to see if we can get a little bit interactive and see what other people's thoughts are on next steps for her. So again, 85-year-old female complaining of initially just referred for an outpatient angiogram for valvular heart disease workup with some chest pain, now coming in, having this angiogram with the Medina 111 severe bifurcation stenosis, and then that mid-LAD nodular calcium, and what people's next steps might be.
Katie, thanks for presenting the clinical scenario and reviewing the angiogram. Thoughts from folks?
Yeah, it depends on what the issue that you discuss with these patients and all their relatives. Just performing a diagnostic angiogram or straightforward for percutaneous revascularization or aortic valve TAVI plus the PCI or cabbage plus AVR.
Exactly.
It depends on what you discuss.
Yeah, exactly. Yeah, so it's kind of two different branches of are we going to plan on pursuing high risk complex bifurcation PCI and, you know, TAVI versus surgical intervention. I will say we calculated her STS risk score to be somewhere around the 8 to 10 range, and her age is 85. So that was certainly taken into consideration.
In this case, I'm not sure that the LAD is significant. Just only calcification and one small nodular calcification. We don't see the intravascular imaging, the minimal lumen area, but definitely the circumflex is 99%. That is the most critical lesion in this one, and RCA is insignificant. So I think you may do the circumflex and then do the intravascular imaging for the mid-LAD nodular calcification, but it would be a tough one because of the calcium. There will be a very high tactile feeling of friction when you pass anything down.
Yeah, absolutely. Yeah, that's very insightful. For sure, the circumflex was very severe. And see if I can get this to play. She did have some distal left main, you know, involvement as well.
If I have this case, I definitely refer to OSU.
Yeah.
So, you know, certainly for folks in their, you know, late 70s, 80s, and 90s, certainly our philosophic approach to most individuals, and certainly in this age category, is percutaneous if feasible. And at 85, we certainly thought that a percutaneous approach would be best. And dealing with any valvular heart disease with critical left main and branch vessel disease is really challenging. And I know as we go through the case and Dr. Lutz shares the thinking, you know, the frame here always for us, as Katie mentioned, is classify it, and it's certainly distal left main, osteal LAD, osteal circumflex. And so, Katie, were you thinking provisional or two-stent strategy?
Yeah, we were in favor of an upfront two-stent strategy in this situation, knowing that we had severe stenoses in both the LAD and the left circumflex. And so, just as was mentioned, you know, we wanted to pay attention to the left circumflex first, mainly because we wanted to wire that first and then do rotational atherectomy rather than put a wire down the LAD and risk any sort of dissection that, you know, anytime we put a wire down an artery, there's a possibility for complication. So our thought was, let's put a wire down the circ, do rotational atherectomy there, and then potentially do the rotational atherectomy of the LAD if we can't get if it's non-dilatable or if shockwave potentially doesn't work. I wish the angiogram would have projected a little bit better to show the nodule in high definition as what we saw, but it's definitely in the at least 80% stenosis there. And I agree, imaging that with IVUS would have been extremely helpful, but certainly difficult to even pass an IVUS down there given the amount of calcium. So our thought was we would do a bifurcation stent strategy with the culotte strategy after we do adequate calcium modification of both the left LAD and the circ. And then we wanted to have a backup for mechanical circulatory support if needed urgently. We would be doing a lot of inflations, and this is going to be likely a 2-3 hour case, and she may not tolerate this. And so we did not plan to put any MCS in up front. Her EF was around the 45% range, but we did put in both a 5 French venous and femoral sheath, just in case we did need to access quickly. And the plan would have been for an Impella supported procedure if for some reason she did not tolerate it hemodynamically.
Great. Damras, do you have a question, sir?
Yes, I will definitely suggest to measure the QCA, quantitative Courier and analysis for the left main Alidine circumflex. This left main is very ugly and is very huge. And the problem is when you confront with a short left main, you have to do pot. Definitely, you have to do pot because when you select the stent size, you have to select the stent according to the landing zone, the distal landing zone, and you have to do pot. And the short test balloon that we have in Thailand, we have the 6 millimeter in length of the balloon to do the pot. And in this left main case, I guess we may have to go to 4.5 or 5 millimeter by 6 mm to do a proximal optimization on left main. Whatever the technique that you are going to perform, QLOD is easy and faster than the DK crush. But we'll see. This is a very, very tough case. And I think, again, I will refer to Osu.
Yeah. I was in the control room, not in the procedure room. Every day is a Dr. Lutz day, but this was a Dr. Galwala day. And, Katie, I would agree. I mean, the circumflex is hanging for a thread. In many ways, you want to treat it as the parent vessel. There is no rescue if you lose that osteal circumflex if you have plaque shift. And so both because of the severity of disease and the acute angulation, I certainly think that working on the circ first while having 2 wires down makes sense. And this, I don't think you're going to get a Sapphire or Takaru down. And with the ugliness of the calcium, I wouldn't be surprised that you need a bird across and an IVL to frac.
Yeah, excellent point. That is exactly, what we considered, and kind of one of the main reasons why we wanted to select the circumflex, first, because we knew that we would likely not be able to pass anything beyond that 99% stenosis at the ostium of the circ. And so from that, let's get into the case here. Okay, so we did end up going right radial and used a 6 French guide. And this was because we were not going to be doing the DK crush strategy. So we felt that 6 French was going to be adequate for us. We actually tried initially with a 4.0 guide, but found that it wasn't quite as supportive as what a 4.5 guide is. So we upsized it to a 4.5 guide. And again, we planned ahead and put a couple of sheaths in the groin in case if we did need them. So we first paid attention to the left circumflex. We were actually able to pass the rotafloppy wire down through the left circumflex, and we started with a 125 burr.
One other comment, Katie, is you have a choice of the rotafloppy or the extra support. I think with the angulation and the fact that you then have an 80-degree bend with a calcified nodule eccentric in the transition of prox to mid, I would use a floppy here and not a extra support, as the extra support would be great for your ostial to prox lesion, but not great and would introduce burr bias and potentially increase perforation on the second lesion that you're going to treat in that circ. So I think the rotafloppy was a great choice.
You can see that from your image. The guiding catheter has a deep seat to near osteal circumflex. whatever you do next, it's very difficult to play around this circumflex because whenever you deploy the stent, you have to take the guiding a little bit back, and then it may flip off very easily because it's I think the curve is too big, and it's approaching into the ostial circumflex. That's why you start your rota from the guiding, tip of the guiding, and then going to the ostial circumflex immediately.
Mm-hmm. Yeah, that's a good point. You know, I think we sacrificed a little bit in the ability to disengage from the left main a little bit here for having a lot of support from the guide, because we knew that we were going to need a lot of pushing power from the guide. So that's why we chose such a big guide. But you're right. Yeah, it is seated very deep. Okay, so we started with a 125 burr at 160, and I think you guys were able to appreciate here that we were able to advance it past that osteal lesion after several runs and down to kind of this mid portion here of the circ. So that's what we got on our angiogram immediately after that run. So the osteal portion is certainly better, but it's definitely not in what we felt a range that we were satisfied with without more rotational atherectomy. So we then used a 175 burr to modify it a little further. And here's the run here that we have of it. So very similarly, we were able to get this to go down pretty much down to here again. Speed it up a little bit for us too. Yeah, okay. And so post-atherectomy here, it's definitely better than what it was after the 125 burr. And so we decided to take a 25 by 15 non-compliant up to 18, kind of both in this mid and the osteal left circumflex here. Sorry, I just need to exit out of the boat. Okay. So then we ended up taking a intravascular lithotripsy here, mainly because that osteal left circumflex, we felt that we tunneled through it, but we felt that, as Joaquin said, that we needed to do some more fracking of the calcium there. So we chose a 2.5 millimeter intravascular balloon. So it's 2.5 by 12. And here we have on the right hand side, the result, which is definitely improved from prior.
And then one of the things I would say about the IVL treatment is that although it was designed for concentric lesions, it does work for eccentric lesions. We presented one of the circulation manuscripts that was published on that. But it typically takes between a minimum of 60 to 80 treatments in order. And sometimes you might think that it is given at 40, but I would really encourage, as you roll your program out and employ it, to do at least, 60, 70, 80 treatments. In this case, Katie, how many treatments did you give? Did you discharge all of them, or did you reserve some for the LAD?
We reserved some for the LAD. So I believe that we gave about 60 here so that we could reserve the other 60 for the LAD, knowing how calcified it was. Okay, great. So we ended up then turning our attention away from the left circumflex and into the LAD and pursued rotational atherectomy here. And so we used over here a 1.5 burr, which is now the third different size of burrs that we've used. And we were pretty happy with the result that we got here, especially at the proximal LAD. We rewired, we again used the rotofloppy wire to get down into the distal LAD. We did have to use a Corsair to help get it up and around some of this osteal calcification, but even then the Corsair would not advance. And so we were able to kind of go as far as we could with the Corsair, which gave us a little bit more of a favorable bend around here to deliver the rotofloppy wire more distally. We then swapped out the rotofloppy wire for a run through here and a run through over here in the left circumflex, so we could pursue stenting. And so now we pre-dilated the osteal LAD with a 2.5 by 15 NC balloon up to 16 atmospheres. And then we used the rest of our pulses that we had kind of in this proximal LAD area and a little bit, a couple of pulses down here. So we kind of went from here to around here with the 3.0 by 12 shockwave balloon, which we already had. After we did that, we then inflated a 3.25 15 NC to high inflations at 26 atmospheres at the ostium.
So if you go back, Katie, and just show me that prior.
Here.
So this is really interesting when you look at the flexion in the first 3 to 4 millimeters of the balloon in the distal segment of the prox LAD. What you see there is there's about a 30 to 40% bend. And remember, it's not just in one plane. And that little area beyond the nose cone, where you have to make that bend in more than one direction with this amount of calcium and extensive plaque, even with burring, can be an area that, despite all this prep, that the stent gets hung up on the transition of the waist of the balloon and the first strut of the metal stent. And so, that's one point. The other is, how high is too high in prepping? And I always get a little uncomfortable, once I'm above 18 atmospheres in these heavily calcified, concentric, calcified LADs. I just never know what's going to pop and what isn't going to pop till it pops.
Yeah, those are really excellent points, and especially on that first point, kind of here, you were talking about this area here, Joaquin, when you come around. Yep. Yeah, and we'll see later on that actually becomes an issue for us later on in this case as well.
Somebody had raised
their
hand.
Okay, all right, sounds good.
Yeah, what is the hemodynamics when you do Rota on both circumflex and LAD? Because you prepare 5 French sheet in the artery, and because she has AI, I think balloon shall not work if anything happens. How is the hemodynamic? Is she tolerate the procedure?
Yeah, good question. We were worried about this the entire time, but actually, to the surprise of all of us, she tolerated it really well. If I remember correctly, the lowest systolic blood pressure that I saw was around 90, 95. But most of the time, her systolics were greater than 100 the whole time. So we didn't end up needing to use our sheaths at all.
I would say, Dr. Lutz was really patient with, the burring. So making sure there were, no decelerations, engaging, backing off, engaging, really not a pecking motion, but an advance and then a retract, an advance, engage, and then a retract. and then pausing after about 15, 20 seconds, and then giving the patient a chance to recover. And it was really technically, in terms of the burr runs for a high-risk patient, I think it was really well done.
Yeah, that's a really good point, Joaquin. We were very deliberate in taking our time between runs, letting the microcirculation clear out so that we could avoid, as much as we can, any issues hemodynamically. Okay. All right. And so with that, we decided at this point, now that we were pretty happy with how things had been prepped, we did want to stent across that that nodule, which we saw, and I apologize that it didn't project very well. But we placed a 275 by 15, deployed it at 14 here. And then we returned our attention to the proximal left circumflex. And so we can see here, again, we've had some substantial recoil of the left circumflex here. And so we decided to do a 325 by 15 and sea balloon up to 26 atmospheres again to really try to prep this area well before placing any stents across it.
And remind me, Katie, in terms of, so you chose a Megatron for radial strength, and remind me about the point of when you did intravascular imaging on this particular case.
Yeah, I think, this is maybe one of the weak points of the case. We did IVUS after all the stents had been placed, so we have that at the end, but not at the beginning here to show you guys.
And the argument was you were already doing everything in our armamentarium to prep the lesions. Exactly. So it wasn't about a decision to burr or not, a decision to IVL or not. You took a Rota IVL approach and NC, and then wanted to make sure that things were opposed, and to Damros's point, to make sure that POTS was done on the left main, if I remember correctly.
Yeah, that's correct. Mm-hmm.
So I think that in a 85-year-old with critical disease and critical valve disease, minimizing ischemic time is important. And the one downside of that is you split your IVL doses and didn't expend them on the nasty circumflex. I mean, you use 60, 70. But one of the things, Damros, as you roll IVL out into the program, is to do it and then to use the ultrasound to see if you see those micropores that have fracked it. And that we didn't do in this case. And so that, as Katie said, is one of our limitations. We're soon going to upgrade to a high-def version of our IVUS system. And so our current system with this amount of calcium is limited in its capacity and resolution to show us that.
Yeah. And so moving forward with our case here, we did end up choosing a Megatron stent. Again, as Joaquin outlined, for the radial strength, because we've seen a lot of ISR occurring up here, and so our thought is that, and we already seen a lot of recoil on this case, and our thought is if we can put something that has increased radial strength there, then we'll do it. And so we placed a 325 by 32 and post-dilated that proximal area to 40 with up to 15. Okay, looks like we've got a hand raise here.
Yeah.
Damros.
I think you have a great great skill, because in this case, I'm cautioned about the stent and cross the calcification lesion. And if you withdraw the stent back, the stent will be migrate. So you
Yeah.
have a great skill. But for me, I'll definitely put in the mother and child catheter to protect anything that can happen, because you do so great of the work. But anyway, caution is better than cure.
Mhm. Yeah, very, very good point. And that's something that we discussed and we were worried about. And so we basically said we knew that we prepped the lesion quite well. If we hadn't have gotten as good of a result of preparation of the lesion, I think stripping of the stent we definitely would have been worried about, and putting a guide liner down so that we could unsheath it, you know, and be less worried about it coming off would have been a really good strategy. Okay, let me just go on to the next slides here. Okay, so at this point, because we've now stented across the circ into the left main, we rewired the LAD and then pre-dilated the stent struts in the LAD with a 2.0 semi-compliant balloon. So our initial plan, which we wanted to do, we wanted to place a stent, you know, kind of from the left main all the way down to where our previous stent was. So, you know, we tried to put in a 32 millimeter stent, and really found that bend is just as Joaquin was talking about, was giving us a lot of trouble. So we brought that out and we tried to do a little bit more pre-lesion prep, and it may or may not show very well, but we ended up with our aggressive predilation here, having a little bit of a dissection in this LAD. So, and she was, again, hemodynamically stable. It was a small dissection up to the previously placed stent. And so at this point, rather than try to continue aggressive strategies, we swapped to a 2-stent shorter strategy and decided that we would try to deliver a 275 by 22 down to here so that it was overlapped with the previously placed stent. And then after we did that, we then again pre-dilated the circumflex stent struts up here, just so that we could really try to get our stent through successfully. Once again, after we pre-dilated the stent struts over here and going into the LAD, we continued to have a little bit more recoil in the left circumflex. So we put the 4.0 NC balloon down and pre-dilated that once again.
I don't think that it is a recoil, but it should be a strut fracture or deformity when you try to open the strut on the main, on the left main. It may be retract part of the stent a little bit away from the original structure.
I see. So more of a we pulled it over essentially when we went to dilate the LAD struts. So then at this point, we were able to get through fairly easily with a 3.5 by 16 stent, and then post-dilated that to 4.0 here. Which, you know, like you said, with all of those post-dilations, especially to 4.0, it could certainly be the left circumflex stent getting pulled over a little bit as well. So we did try to reform the stent struts there and took a 4.5 by 8 NC up to 15. So that, yeah. And then at this point, we were pretty happy with the way that things were looking here, and we did the final kissing balloon inflation, and we did at that point with just a 3.5 by 15 and compliant balloons in both the LAD and the left circumflex. You know, it looks like there were so many images that we saved. I forgot to save the image and present to you guys where we did proximal optimization technique of the LAD, which, if I recall, was at least a 4.5 NC balloon, which we took up to around 16 atmospheres in the left main. So we did do that. I just omitted that on accident from this presentation. And here we have our final angiographic image here as compared to what we started with over here on the right. And once we got our final image is when we, I've got some IVUS images to show you here. All right, so this is our LAD, and I've got the MSA saved on our screen from that. So I do have that for you, but I'll just show you the run here and what it looked like. So it looks, you know, pretty well opposed, potentially a little bit of we had a lot of calcium to deal with, and so there's a little bit of potential, you know, under expansion here. And then as we come in to the left main, it also looks very well opposed. And then pulling into the guide catheter, we, you know, felt we had a reasonable result. The left circumflex, it was.
And what I would say about that, Katie, is,
Mm-hmm.
you know, when you did your cross-sectional areas, you know, this is a heavily diseased vessel. You're
Mm-hmm.
not going to get perfection.
Mm-hmm.
And one of the risks, and again, this is 85-year-old woman, is that if you oversize that, then you perf, and then she will die with her valvular heart disease. And so this is where the search for perfection will derail you. And, you know, we're not used to seeing the minor axis, you know, there to be a minor and a major, but the minimal cross-sectional area was reasonable.
Mm-hmm.
And thinking about where we started and where you landed, you know, this is really good.
Yeah. And then I just got the left circumflex to show you. To be honest, we could not get the IVUS down very far with that bend. And again, I'll show you what the MSAs were. But where we were able to get it down to looked reasonably well expanded. And again, you can just see that 360 degrees of calcium that's around in there. So we were very happy with that. And here's the MSA that we calculated. So LAD, this is the smallest area I could find, which is, you know, not perfectly drawn, but somewhere around 9. And then the left circumflex for where we were able to deliver to, and at least at the ostium, was 6.2 millimeters squared. So we were quite happy with that. So I'm gonna show you some summary slides and then go over calcium modification strategies and so a couple of complications which we've had with intravascular lithotripsy, which is not, you know, free from complications.
So Katie, on your number one statement, guide support is key for this, absolutely. And although there are challenges of being slightly oversized, any guide that would have been on the slightly undersized or normal sized, in order to get aggressive, you would have to push into the sinuses. And in that situation, you would worsen the magnitude of AI. And so always remember, in these cases, if the hemodynamics begin to deteriorate, think about interfering with the aortic valve function and lifting your guide.
Yes. Yeah, that was key. We spent actually probably a good 15 to 20 minutes on just getting the guide in the way that we wanted to, and when we weren't satisfied, we swapped out to that larger XB45 guide. And throughout the case, you can tell from the images there, the guide really didn't move. You know, we weren't having to battle anything coming out at all, or like you said, AI. The other part was, you know, we had 2 vessels, which we thought we were going to have to do rotational atherectomy. And so we elected to do the worst of the 2 vessels first, so that we, we could kind of plan the LAD after that. The other piece was that you saw us use 2 different sizes of rotational atherectomy, and I think that helped us to get that 175 burr then down after we went at it with the 125. I do really think that the combination of lithotripsy, especially for the proximal left circumflex, helped us out a lot. Just fracturing it after we were able to get a good tunnel through, and then again consider a megatron and osteo left circumflex. So from here, I'll move on to calcium modification. Guy has a really nice document about calcium modification and strategies, so we don't need to go through this today. This was mostly just so that people know that it's there, what the criteria are, and then, moving down this algorithm, choosing what you may want to do, whether it's atherectomy, IVL, or some sort of a cutting calcium, cutting or scoring balloon. Okay, so complications of shockwave. So I think in general, shockwave is thought to be very safe. It's essentially a balloon. But complications can still occur. And the Disrupt CAD study really included quite a few patients to show that intravascular lithotripsy was quite safe, but it did have some important exclusion criteria, so no ACS, and they didn't really have hardly any higher risk calcium, as in osteo left main, or in any lesions that were non-dilatable. So our patient here would not have even been included in the Disrupt CAD study because there's no way we could have passed any IVL balloons. And so we're still kind of unsure about, the safety and effect, the safety really of intravascular lithotripsy in higher risk populations. But regardless of that, you'll see here, down here, any angiographic complication, really post IVL 2.1%. So pretty low risk. And most of that was from dissections or slow flow, and they had no issues with perforation here. So 0% of this population had that. So more recently, and I think that this was published around sometime earlier this year, they took a look at a different population where higher risk patients were included, a different registry, and they wanted their goal was to identify procedural complication rates in patients who really weren't just like hand selected for the Disrupt CAD study, and to really identify the risk factors that can contribute to the occurrence of complications in a higher risk population. And so looking at the complication rates, so they're really fairly similar. Coronary dissection, like 2%. They did have somebody who had a coronary perforation, so around 1% range. So 0% can't happen whatsoever is probably unrealistic. Some slow flow, slow reflow, but the overall complication rate was fairly similar. And most of the complications happened immediately after intravascular lithotripsy. And here's the way that the people responded to the complications. Fair amount stent. A few ended up needing a covered stent. Some inotropic support or vasoactive support. Very, very rarely was more aggressive things like a pericardiocentesis needed, or these types of things. And what they really were able to identify was that the higher balloon to artery ratio was the only statistically significant risk factor. So a higher balloon, if you can imagine, larger balloon, for the artery size was the really the most common feature for all of them. Okay, and so really this is again just showing like it's low risk of complications, but of those complications that do happen, coronary dissection did occur, coronary perforation did occur. So just things to be mindful of. Okay, and I just want to show you guys a couple of cases which have happened actually within the last like month or 1 to 2 months for us. So this patient who had stable coronary artery disease, these are very, very short presentations, and had this mid-LAD calcified stenosis for which we, thought that we'd sized a balloon appropriately for the vessel, and went down and had a little dissection here. We had considered drug-coated balloon for this, but we ended up just placing a stent across it because of the dissection.
If you just go back on the
yeah.
So you can see on the left hand, just above the diagonal, the area that we were concerned about, and the dissection was I think, direct result of the balloon rupture, not necessarily per se. We had only given, I think, what was it, 10 treatments, but nonetheless, it was related to the IVL balloon. And I must admit, I've had a couple rupture over the course of the several years we've been using it, but I hadn't had one rupture in which we had prepped the lesion with an NC balloon on a straight segment like this, but it immediately ruptured.
Mm-hmm. Yeah,
you mean the IVL balloon rupture?
Yeah.
Yeah.
Yeah, and is there anything that has been left behind? Because let's go back to the Wolverine, the cutting balloon, when we try, and we are most afraid that the cutting balloon will rupture and then we leave the blade inside the vessel.
Oh.
Yeah, nothing's detachable within the emitters, so no.
Yeah, thank you for catching that, Joaquin, on the balloon rupture. That was the key part. It was fine until it ruptured, and then dissection.
It took a little bit longer following the rupture to see the blood emanating into the delivery system. So I was going up and I couldn't see anything. And then I pulled back to see, I said, well, maybe thinking in my mind there was rupture, and no blood came back into the insufflator. And I went up again and didn't see anything. And then I pulled back. And then after about 5 seconds, I noticed blood coming in. So it was slower to see the blood in the insufflator than with a typical balloon in this case.
And then the second complication that we have, if we take a look, darn. Okay, so this isn't going to play. It looks like for some reason cannot play media on the left-hand side. But I was hopeful to play a high definition of the left circumflex, which had an eccentric calcification, calcified lesion, kind of going from, if we look over here on the right-hand panel, around this area to kind of going into the OM, and it was about 80% stenosed. And so you can see here we did pre-dilate the lesion and then used a 2.5 by 12 IVL balloon. You always inflate it to 4 atmospheres, and again the balloon ended up rupturing here for us, and we got an intramural hematoma here. You can kind of see the blood coming out right here. Treatment for that, we ended up inflating a balloon, and it just kind of self-contained, and there was no dye staining that was seen towards the end, even before we stented over that segment. And with that, that's everything that I have to present to folks. I'd like to open it up for discussion and comments.
Thank you. That is a very great case that you do the Rota IVL. We learned a lot from you. Thank you very much. And may I ask one question? Do you use just only 6 French guiding catheter or 7 French?
Yeah, that's a really good question. We have used larger size catheters, particularly if we're going to be doing a CTO, or we're going to be using, trying to deliver like multiple balloons at the same time, or multiple stents at the same time. I think because we chose a culotte strategy, knowing that going up front, we chose the 6 French, which allowed us to stay radial in this 85-year-old woman. I'm not sure that her radial would have accepted a 7 French guide. So yes, we have used it, and particularly so for CTOs.
Yeah, it
So,
might be very friction
Damras?
when you press the 2 balloon for kissing. T5,
Yeah.
T5, both.
Yeah,
there
there was a lot of friction there. That's a really good observation.
Yeah, Damras, I would have used a 7 in this case, but I wonder if part of the patient doing well was less ischemia because we had a 6 and not a 7 occupying the left main. But we chatted about it, and I mentioned to Doctors Lutt and Galwala that I myself would have used a 7. They definitely used the 6 to its maximum capabilities. Well, I hope that that you all enjoyed this case when it was being done. As it was being done, I said to Katie, "Let's share this with our BDMS friends." I still didn't know what the outcome of the case was, but nonetheless, it was going to be a great, thoughtful case to share with you. And so we didn't talk much, Damras, about multimodality plaque modification. And occasionally it's done when you have both superficial and deep. And so I thought it was a fun case to go through.
Thank you.